There are many reasons for undercoding. One of the main reasons is we're human.
Yeah.
So, we're writing so many notes every day, and it's impossible for a clinical coder to actually read every single note. We can't expect them to. Like, it's too many. So, they have to be selective in what they read and what they code.
Yeah.
So that's a human limitation. Now the question is, what can AI help with?
Yeah.
And definitely those points, right, with improving the accuracy and picking up things which a human might miss. And also with AI, you're not really limited by the number of documents. We can read as many documents as we want,
Yeah.
and we can even go back as far as we want.
Yeah. I think this is probably the most obvious use case you can think of when you are thinking about how can AI help hospitals.
Yes.
You have an AI helping you to do that.
Yeah.
Instead of you finding the code for diabetes.
Yeah, I can't be scrolling through like drop down lists. What it should do is read the notes and say, okay, I've read your clocking document.
Yeah.
And we see these things. Do you think this is the primary diagnosis? Yes or no? One click.
Easy.
Like, it needs to be seamless. Is that saying? Like, a good technology should feel completely seamless. Should feel like magic. It should be part of your work.
Yeah.
It doesn't add to the burden.
Yeah. Not add more work.
Yeah.
Hello and welcome to another episode of the Dev and Doc podcast, where doctors and developers talk about how can AI improve healthcare. I'm Željko, I'm the developer, and with me is...
Josh, I'm a neurologist and AI researcher in London.
Awesome. So, what are we talking about today?
Today, we have been talking a lot about automating administrative burden as the first goal of AI currently. And we talked about it. I want to go a bit deeper.
Nice.
In this case, I want to talk about clinical coding.
Everyone's talking to me about that.
Yes.
So the first thing everyone mentions to me, can we do clinical coding?
Yes.
So I'm very interested in this topic. Yeah.
And just for context, this is a huge use case, and there's multiple companies in the last few years especially trying to crack this problem. In the Y Combinator, the venture capital company that funds different companies. In the last run of the healthcare investments, I think 5 out of 9 of the companies were to automate clinical coding. So this is a big thing, a really big thing. So to begin with, can I just ask you what you understand about clinical coding so far?
So I know a bit. Basically, I know that's used for something for hospitals to make money. It's something that happens at the end of an episode where clinical coders go through what happened and try to basically find what was the diagnosis, what were the medications, what happened in that episode so that they can charge whoever.
Yeah, I think that's a good way to do it. I like to think of it as a thought experiment. So imagine we're very early in the, 1800s, and we're just building up the first 10 hospitals in the UK. And all kinds of patients are coming through. They have all kinds of different diseases. And, the doctors see them and they're all writing different things. They're writing in text, I think this is what's happening with this. We think it's leprosy, or this crazy, we think it's like sewage water. I don't know what diseases were back then. The question is, how in the long term can hospitals actually know what's happening across the board between hospitals like down south or in Scotland or in England? How do they know what the big picture is? And the best way to do that would be to map everything that's happening onto some kind of agreed structure. Does that make sense? Yeah. So in a way, clinical coding is basically, like you said, going through each episode, each patient, each encounter, and trying to bring everything into a standardized ontology. Now, different countries can have different standardized ontologies. The one that we're using a lot ourselves is SNOMED CT, but there's also ICD-10, there's also DSM criteria. All of these are just different ways of classifying diseases. So that's the idea. And what's the benefits, you ask? Well, the benefit is clear. If you can know exactly what's happening across the country, you can help direct funding on the places that have certain problems, and you can also see on a global scale what are the diseases that are troubling this region or that region.
Yeah.
And now, more importantly, because we live in a society that's also very, money driven, especially in the US, you can see clinical coding is huge there. Why? Because every single episode has to be coded, and you get paid according to what happens, right?
Yeah.
So if you undercode, as in you don't map everything that's happened to a patient, then the hospital gets paid a lot less.
Yeah.
Yeah.
I mean, is that the same in the UK, I assume?
It's on and off, actually. So in the UK, we have something called payment by results. Yeah. And hospitals have traditionally followed that, I think. But during COVID, they decided to go back to the older way, which was just to fund the hospital based on the region, and everyone gets like a set price.
Oh, okay.
That was obviously because during COVID, there was uncertain levels of activity, and it's a pandemic. So they said, okay, we shouldn't be using this to drive how much money we give to hospitals. We should just be, funding them so they can focus on treating patients.
Yeah, that makes sense.
Yeah, but now we have actually gone back to payment by results. So once again, clinical coding has become this huge topic that we're trying to crack.
Okay, so I would then assume there are backlogs. I mean, if we didn't properly do that or properly track that through COVID, there are many backlogs. And I do think the thing that people have mentioned to me the most is undercoding.
Yes.
So which I assume happens everywhere. And simply, that means that if a coder goes through an episode of a patient, they miss things.
There are many reasons for undercoding. One of the main reasons is we're human.
Yeah.
So, we're writing so many notes every day, and it's impossible for a clinical coder to actually read every single note. We can't expect them to. Like, it's too many. So, they have to be selective in what they read and what they code.
Yeah.
So that's a human limitation. But also, the clinical coders are very, very good, but we're still human and we still make mistakes. Sometimes we miss things. So, we find that if you're reading notes after notes, it's very common.
Yeah.
Like, we do this ourselves. Like, I annotate documents to fine-tune models. After like a few hundred documents,
you don't know anything anymore.
You're just kind of on autopilot, and sometimes you're not thinking, or you skip a few lines and you miss something. So that happens. Clinical coders also do have rules that they have to follow. So there's certain scenarios where they cannot code things if a clinician has not stated that explicitly. So these are the problems. Now the question is, what can AI help with?
Yeah.
And definitely those points, right, with improving the accuracy and picking up things which a human might miss. And also with AI, you're not really limited by the number of documents. We can read as many documents as we want.
Yeah.
And we can even go back as far as we want.
Yeah. I think this is probably the most obvious use case you can think of when you are thinking about how can AI help hospitals.
Yes.
And obviously, I mean, it is relevant because on one side, as you mentioned initially, you get the general picture of a whole country, of what is happening, what are the diseases. And of course, on the other side, I mean, you get payments for hospitals, which is otherwise hospitals fail, so we don't want that, so that's important. And to be honest, this is like, I cannot understand why did the NHS not do this. To me, this is unbelievable. This is like the most obvious things, not today. This was the most obvious thing 10 years ago, more than 10 years ago. Like named entity recognition on this level, you don't want to replace coders. No one wants to do that. This is an aid so that you don't undercode, so that you don't miss things. And basically what this tool will be doing is just suggestion.
Exactly.
Occasionally suggesting, oh, did you see this? And that's what you need. I mean, when you're reading, as you said, when you're reading through 1 million documents, after 10 hours, you don't see letters anymore.
Yeah.
Everything is blurry.
So, you feel lightheaded, things just like blur into one.
No, exactly. Imagine a Friday afternoon after like the whole week of coding and at the end of an 8-hour shift. It's like you don't know what you're coding anymore. So you just want a tool that will highlight.
Yeah.
just tell you, oh, does this make sense?
Exactly.
And then you say yes or no.
Yeah. Look, I don't know if there have been efforts to push this earlier, like in the last decade, but definitely now, like everyone's talking about NLP. And, the named entity recognition we've talked about extensively in our previous episode. Why don't I just talk a little bit about the use cases that we've been doing and what my experience is from clinical coding. So I'm not going to go too deep into the training cycles. We covered that in the de-identification episode where we talked about how you can fine-tune the annotations. So in order to teach the model to code well, you need to give it a fine-tuning data set for that specific use case. So one thing we published and one thing we did a couple of years ago now was actually coding a stroke audit. So there is a national stroke audit called the SNAP audit. Essentially, as I described, every single stroke unit in the UK has to code for certain things like the disability of patients, how they came in, what kind of stroke it was it the bleed, what kind of treatment they had, what kind of complications. And actually this national audit has had a very big impact on stroke care in the UK as a whole. So it's just to illustrate how powerful auditing and coding can be. Because what happens is every underperforming hospital can compare themselves to the national average and think of ways and have discussions as to how we can improve that care. Like if you're falling short in one area, we're like, what's the different hospital doing? How can we improve? Yeah. So we actually did that. We trained a MedCat model.
MedCat
is the medical concepts annotation tool, which we talked about in our named entity recognition episode. Jelko essentially built this tool, and I really spent my time deploying this and working with different clinicians. So in this instance, we used a named entity recognition tool to run through all of the stroke documents that a patient comes in with. And for our use case, we were interested in the comorbidities. So whether they had high blood pressure, diabetes, heart failure, or atrial fibrillation, all of these are big risk factors for strokes, things that we definitely want to pick up on, and things that will also lead to an increased coding depth. So this means not undercoding, but increasing the depth of coding, which usually can lead to a higher payment for those hospitals. And we showed this, that the MedCat model performs as good as clinical coders, which is incredible. And
again, this is the only point is just that it can be used to help. If it performs as good as clinical coders, what if you combine the two?
Exactly.
It can be faster, it can be more efficient, and save more money.
Exactly. So none of this is about replacing clinical coders, because obviously the AI model still makes mistakes, and depending on how you fine tune it and what documents you choose, it can give false signals. So that's where you need the human in the loop and the clinical coder.
And things change over time. I mean, over time you either get a new disease, or some rules change, so you have to now annotate differently. So that is why, like, the moment that things change, you need a clinical coder to teach the AI. So it shows the AI how things have changed and what needs to be done. And then of course they just continue working together again. So once the AI learns, the clinical coder again can use the AI to supplement whatever they might have missed. And I still want to go back to how inefficient the NHS is. How I know that there were no efforts to really do this, because you just mentioned, you and I have basically made this tool, MedCat, to do this clinical coding. We have made it free. So this is like open source. This is you don't have to pay for it. It is free. There are tutorials. There is everything you can imagine so that you can use it. We even have the models, like pre-trained models. So you don't need a clinical coder that needs to now train the AI. No, the models are trained, ready. You just need to go onto the GitHub account, download everything, download the models and the package, put it into your hospital together with your clinical coder, and that's it. So like 2 days of work. No one has done it.
Oversimplifying it.
Of course. I'm oversimplifying a bit, but
But have you had pushback, like, from different trusts or?
No one. I mean, I cannot go around and be and telling
salesman.
everyone like, "Oh, do it."
You need to, man. You need to. This is how you push forward.
We have tried this a couple of times. I mean, it is strange that this is still like not properly implemented at King's College Hospital, where basically all of this was validated and done.
Yeah.
And again, it is very hard just because it is not really supported by the high ups in the NHS. So the NHS as a whole.
Yeah.
The managers, the whatever. It is, of course, when I go to a clinical coder, he's like, "Oh, I want that."
Yeah.
It is like, can I start using it tomorrow?
Yes. I mean, I have worked with clinical coders, and they tend to be very impressed with what MedCat can do. And if there can be a product which can just highlight things to them, I think it would be really useful.
Of course. I mean, it makes no sense. Why wouldn't it be? It is still strange that, like, not strange. It is in every other almost job we do, you have helpers, you have helping tools. You have, like, when I'm coding, I have my coding co-pilot. So when I'm programming, I have my co-pilot for programming. So when I need to write a simple thing, or when I have made a mistake, it highlights, "Oh, you made a mistake. Do you want to fix it?"
Yeah.
And if you are doing a clinical coding task, nothing. You just need, you have your document in front of you. You are going through that, and you're just marking the diseases. Makes no sense.
Yeah. Yeah, look, we have many use cases. The stroke was one. We've also showed it in orthopedics. Another great use cases are surgeries and minor operations, because those things are still sometimes done on paper. And if you could automatically code that would be save a lot of time and effort. The point I wanted to make is there are many cases where AI can assist clinical coders heavily and lead to a much better result.
Yeah.
And we are working with clinical coders every single week now to try and build more useful use cases.
Yeah.
So, maybe it's a bit late. I appreciate what you're saying in terms of the adoption, but we are adopting, and now we're heavily exploring these use cases. We're really building out MedCats and AI models for clinical coding.
No, we are doing something. So I think it is good.
Yeah.
We should do 1,000,000 times more.
Yeah.
We are still doing this, like this is currently being done here in London, based in the hospitals we work in, mainly because those are the hospitals we work in. This is not hard. This has to be deployed everywhere. And not because, there is no like any other interest from my side or anyone's side of the people who have made this, except for this will help patients. I don't get it. Why is the NHS not doing it? Like, I cannot find, if there is anyone from the NHS listening to this, please tell us. Tell us, like, why are we not doing
this? What are the
Or
barriers?
what are the barriers? What do we need to do so that this is deployed in other hospitals? We have tested it, we have published papers, we've shown it works, we have all the models ready. Use it. Basically, it's just up to everyone else to now use it.
Yeah. I guess the bigger question is, just to finish off, is why are so many companies also trying and failing? And that goes into a much wider and bigger picture. Is it the healthcare uptake? Is it access to data? Is it the lack of fine-tuning of the models? Is it education of clinical coders and staff to actually use those technologies?
I think, of course, as always, is everything.
It's multi-factor.
A bit of everything. I still think that probably one of the major factors is that somehow the NHS is like closed up. It is very hard to change things inside. It is very hard to get new ideas, new companies into it, and especially companies using AI. People are very careful with the data. And we were mentioning this in the past. People are overly careful with the data. If the data will never leave the NHS and another company is just coming in to help clinical coders, we should really support these. I'm sure as a patient of the NHS, I want to support this. As a user of the NHS, not a patient. As a user of the NHS, I want to support it, because if those companies will help me, do it. They can have access to my data.
I agree. We should be pushing forward with a bit of caution, but
of course,
AI needs to be implemented and deployed a lot more than what it currently is.
Okay, so I think it is obvious that we need AI. And some of the things that it will help us with is really this undercoding. But is there something else you can see that where it makes, or why would it make sense to really use AI for clinical coding?
Yeah. I think this human in the loop thing is great, and giving suggestions would be amazing. And one thing I have noticed working with many different clinical coders is that each of them have a slightly different approach, and this is just human nature, right?
Yeah.
Some of them may read more documents on average. Some may go back a little bit further down the line to clarify certain things that may be mentioned in the current letter. And one thing that AI would be great is to unify and kind of get everyone back to a certain baseline, because because of the variation, it can be a bit tricky to know whose code, which approach is the best. But with AI, you can essentially go through all of the notes and just bring it to the front and say, okay, this is blah, blah, this is likely blah, blah, blah.
Yeah.
And the great thing about AI is you can also bring it back. So if you suggest the code, you can suggest what context this was mentioned in. They can say, oh, did you see this note from 5 years ago? It said that the patient had diabetes and was taking some insulin. Do you think the patient has diabetes? Do you want to code it now? So that would be really useful.
Oh, okay. So it would also then go into bias reduction, because assume every person has a slight bias towards something. And if here also, again, very important, the way you train the AI.
Yes.
Again, going back to what we mentioned in the last episode, or one of the last episodes, was basically that you need many different people that will train one AI so that these biases get like leveled out.
Exactly.
If you have 10, 20, 100 different people training the same AI, then these biases get leveled up and you get a very, very nice general AI that now doesn't have almost any biases.
Yeah, exactly. And that's a great point, because clinical coders, like doctors, also specialize in certain subspecialties, because obviously you can't expect a clinical coder to know in depth like cancer knowledge and chemotherapy, as well as really rare like genetic hematology diseases. So, each coder focuses on one or two like special domains.
Yeah.
And if you had a more generalist AI model, sometimes these domains overlap. And if you have an AI model that can explain certain abbreviations or certain jargon from other specialties that have trickled in to the documents they're looking at, that's also very useful, because then you get a more rounded kind of base knowledge for everyone.
Okay, yeah, I get it. So, we are just saying everything is
good.
Everything is good. Yeah, you should basically be using AI for this, because I cannot stress this enough. This is the most perfect use case that you can imagine where AI can be used in healthcare. And it is the impact, as we were basically just going through this, it is very big. It's not just hospitals get paid. It is many, many other areas where it is contributing to population health.
Yeah, population health, research, setting the standard of the country and the hospitals.
Precision medicine, all of that, somehow these contributes, because once you have coded notes, then you can train your other AI models, you can do whatever you want with that codes, and you can do statistical analysis, you can find the efficiencies or problems in a hospital, find what's good in a hospital so that you can spread that to other hospitals. There is an unbelievable amount of benefits to doing this. So I think this has to be done.
Exactly.
And I'm again saying, if there is someone from the NHS, tell us. Just tell us why is it not being done and what can we do so that it is implemented.
Yeah. And can I just, for the closing point, I wanted to just talk about our new electronic health record, EPIC, that we're using now. And there have been attempts from EPIC to make clinicians code a bit more. So now, in order to save certain documents, it asks us to basically, really put down what we think and really choose the diagnosis in the criteria. But still, that's not enough. We still, we're very busy on the ward, and I know for a fact we're still not coding everything. So even with changes in design to the electronic health records and how users interact with it, this is still something that needs to be tackled regardless.
Yeah.
And the other thing is clinicians get very fatigued. Everyone's complaining how we need to be doing so many clicks now in order to save a note, to say, you can't save this until you click this diagnosis, click this comorbidity, click this VTE risk, click this thrombosis risk. it's very tiring and it leads to fatigue.
Yeah. So I just want to go back a bit here just to say like Epic is basically a hospital system, an electronic health record system that is currently being implemented, or that has been implemented basically a couple of weeks ago into the King's College Hospital and Guy's and St. Thomas's and a couple of other hospitals.
It's nice. You know, there's a new shiny electronic health record with some extra uses and functionality, but clinical coding is still a problem.
New shiny, I am very much against that. I think like Epic is showing how things should not be done. And this is like, they are forcing humans to do all the work. So instead of instead of assisting clinical coders, instead of assisting doctors, they basically said like, okay, we need to structure the data. So instead of you just writing down this person has diabetes, now you have a drop down and you have to find diabetes. You have to code it yourself. And this is adding more work to already overworked clinicians. I found very few people who like Epic. I do think this is obviously like a tool that is made by coders, by programmers, by software engineers. I think everything is there. It is just extremely inefficient. It has to be done with AI in the middle, so that all of these things that it would be nice to have or nice to do, you have an AI helping you to do that. Instead of you finding the code for diabetes.
I can't be scrolling through like drop down lists. What it should do is read the notes and say, okay, I've read your clocking document and we see these things. Do you think this is the primary diagnosis? Yes or no? One click.
Easy.
Like, it needs to be seamless. Is that saying? Like, a good technology should feel completely seamless, should feel like magic. It should be part of your work. Does not add to the burden.
Not add more work.
Exactly.
Whenever I see Epic, I'm like, oh my God. It is awesome because for me, like a coder, for someone like a programmer, it is very good just because if Epic would have been used properly, we would have a lot of structured data, we would have a lot of granular data, we would have everything organized nicely. So then when I'm coming to a hospital, I can access that data, I can do whatever I want with it, I can do all my AI training and everything else. But for doctors, for anyone else, it is really bad. And it should be made more efficient, again, with AI. I mean, that is the whole purpose of AI, is just to make the job
our
easier.
lives easier. Great. I think we've hammered home this point quite heavily. So reach out, talk to us, like and comment. Tell us what you think about clinical coding and how you think we can automate this a bit better in the future.
Awesome. Thank you very much for listening, and we'll hope to see you next time. Bye-bye.
See you on the next one. Bye.